Okay, so moving to virulence factors. Here's a question. A 34-year-old male returns from India and upon arriving home is diagnosed with pneumonia that is resistant to multiple antibiotics and particularly to imipenem. What is the likely virulence factor which caused the pneumonia? Okay, so the answer is the New Delhi metallo-beta-lactamase. So we have to remember this, alright? It's more like a cramming thing. New Delhi metallo-beta-lactamase 1 is the mutation that leads to carbapenem resistance, typically found in Klebsiella, alright? Klebsiella pneumoniae, remember. E. coli, Enterobacter cloacae, and others. First line management is the old antibiotic colistin, and second line is tidecycline. Number 1, colistin, tidecycline, CT. You can remember it by CT. C, colistin, T for tidecycline. Okay. D-alanine D-lactate radiation leading to loss of affinity to antibiotics, the mechanism of vancomycin resistant enterococci. Okay, so vancomycin resistant enterococci, because vancomycin binds to DLA. Okay, next is these stuff, they will not come into the exam, but let us just go through it. That alteration to penicillin body protein 2 is the mechanism behind methicillin resistant Staphylococcus aureus, which is MRSA, and in MRSA it is mainly the mutation in MEC gene, MEC gene, okay, and the presence of MEX, AB, or OPRM, efflux pumps. Remember that resistance to lectins. Okay, how we can remember this? Start from the last. Actin rockets. Okay, so remember this. A long man. Okay, a or active long man. Actin rockets, Listeria monocytogenes. Okay. Now you move back to the bacteriophage. Corynebacterium diphtheria. B for bacteriophage, D for diphtheria. BD. Remember, bacteriophage, Corynebacterium diphtheria. Spore formation. BCC, Bacillus anthracis, Clostridium perfringens, Clostridium tetani. Lecithinase alpha toxin. Okay. Clostridium perfringens. And diglutamate polypeptide capsule. Remember, keep it as when it's a capsule. Okay. So keep in your mind the CAB, CAB or CAP. Okay, so when you remember C for capsule, A for anthracis, and B for bacillus, CAB. Remember there is another capsule which is known as PRP capsule and polyribosyl phosphate capsule. So there are two capsules. One capsule is bacillus anthracis, and second capsule, PRP capsule, is saying high, and high for Haemophilus influenza. Okay, so PRP capsule is saying high, and we will remember it by Haemophilus influenza, and the D-glutamate receptor by CAB, actin, Listeria monocytogenes, and I make you remember B and D, bacteriophage, Corynebacterium diphtheria, spore formation BCC, Bacillus anthracis, Clostridium perfringens, Clostridium tetani. Okay, so now we are left with the two. How we will remember them? The M protein, Streptococcus pyogenes, and the IgA is for Streptococcus pneumoniae, Haemophilus influenza, and Neisseria. Okay. Moving to the next. Question number 107. A 29-year-old man presents with a 9-day history of watery diarrhea. Remember, watery diarrhea that developed 1 week after returning from India. He had travelled around northern India for 2 months. On examination, he is apyrexial and his abdomen is soft and tender. What is the most likely causative organism? Giardiasis. Why giardiasis? First of all, watery diarrhea. No bloody diarrhea, so amoebiasis will be ruled out. Okay. Why giardiasis? Because of ingestion of contaminated water or food, and it is mainly in areas where there is poor sanitation, and here they are saying that he is returning from India. Okay, specifically the northern India for 2 months. Okay, so the incubation of Giardia limbiasis is for 1 to 2 weeks. Okay, amoebiasis, it's called as Entamoeba histolytica, can cause diarrhea and endemic in countries. How it is bloody, as I've told, that how we will rule out amoebiasis? that there is no bloody diarrhea. Okay, so we will rule out this. How we will rule out Campylobacter? Okay, so Campylobacter, Shigella and Salmonella are bacterial infections that can cause gastroenteritis. However, these infections usually present with more acute onset of symptoms including fever and abdominal cramps. Alright, next, giardiasis. Giardiasis is caused by the flagellate protozoan like Giardia lamblia. It is spread by fecal route. Remember, I have told you in the previous video that amoebiasis, E for feco, F-E-E, the sound of E, feco, and O for oral root. Remember that giardiasis is also feco-oral root. Okay. Risk factors: foreign travel, swimming, drinking water from a river or lake, male-to-male sexual contact. This is really important in this case. Okay, male-to-male sexual contact. But remember, there will be non-bloody diarrhea and steatorrhea. Steatorrhea means that stools are difficult to flush and there is problem with the malabsorption. Of course, there is a problem with the malabsorption because the flagellate protozoan has caused it. Okay, and bloating, abdominal pain, lethargy, flatulence, and all the stuff going on. These are the simple features which are mostly going in all these kind of stuff, in all this kind of protozoans. Okay, remember that giardiasis is a flagellate and Giardia lamblia. Okay, investigation: stool microscopy for trophozoite and cysts, sensitivity of around 65%, stool antigen detection assay, greater sensitivity and faster turnaround time than conventional and microscopy methods. PCR assays treatment is metronidazole. Okay, do you remember the treatment of amoebiasis, or should I repeat that? What was the treatment of metronidazole and luminal agent, which is the diloxinide furoate, and the treatment of giardiasis is also metronidazole, stool microscopy, stool antigen detection assay, and PCR. Other buzzwords are male-to-male sexual contact, Giardia lamblia, flagellate protozoan. Alright. Next question. As soon as we are moving further, then there will be repetition of the topics and we will be covering the questions more easily than previously. Okay, but I would highly recommend to tell you each and everything which I need in my exam regarding my exam preparation, and I will let you know everything which should be needed. Alright, we review a 14-year-old boy who is recently migrated from Russia. He was involved in a car accident 2 years ago and underwent an emergency splenectomy. So there is emergency splenectomy. Following the accident, he takes penicillin V on daily basis. He is unsure of his vaccination status. We know now that whenever there is a splenectomy, we have to give pneumococcal vaccine. Okay, so he is unaware of his vaccination history. Which organism is he particularly susceptible to despite taking prophylactic antibiotics? Okay, so penicillin V would protect him against Staphylococcus pneumoniae, but not Haemophilus influenza. Why? Due to production of beta-lactamases by the organism. Okay, so penicillin V will not act on the beta-lactamases. Okay. Alright, so that's why Haemophilus influenza is not covered by penicillin V. Splenectomy. Following a splenectomy, patients are particularly at risk of pneumococcus, Haemophilus meningococcus, and Capnocytophaga morsus infections. Vaccination, if elective, should be done 2 weeks prior to operation. And which vaccination? Haemophilus influenza B, meningitis A and C, and annual influenza vaccination. Pneumococcal vaccine every 5 years. Okay, so which vaccines? Which one vaccines? Okay, so number 1 is Haemophilus influenza, meningitis A and C, annual influenza vaccination, annual every year, and pneumococcal is for every 5 years. Next, antibiotic prophylaxis. Penicillin V, unfortunately, clear guidelines do not exist of how long antibiotic prophylaxis should be continued. It is generally accepted through that penicillin should be continued for at least 2 years and at least until the patient is 16 years of age. Okay, so at least 2 years or the patient is at least 16 years of age. So indications: Surgical aspects. Trauma, 1/4 are iatrogenic. Okay. Number 2, spontaneous structure. EBV, Epstein-Barr virus, we've heard about previously that EBV can cause infectious mononucleosis and cause splenomegaly, and when there is splenomegaly, then cause of the trauma causes splenic rupture. Hypersplenism, in which cases there is hypersplenism. Hereditary spherocytosis, remember that in HS, hereditary spherocytosis, MCHC is high. Okay, so that is an important point in this disease that I remember, and I thought that I should tell all of you. Next is elliptocytosis. Malignancy, lymphoma and leukemia. Splenic cysts, hydrated cysts, splenic abscesses. Elective splenectomy. So elective splenectomy is a different operation from that performed in the emergency setting. Spleen is usually large, sometimes massive. Okay, most cases can be performed laparoscopically. The spleen will often be macerated inside a specimen bag to facilitate extraction. What are the complications? Hemorrhage may be early and either from short gastrics or splenic hilar vessels. Next is pancreatic fistula. Okay, from nitrogen damage to pancreatic tail, thrombocytosis, prophylactic aspirin, and encapsulated bacteria infection, streptococcus pneumonia, Haemophilus influenza, and Neisseria meningitis. Platelets will rise first. Therefore, in idiopathic thrombocytopenic purpura should be given after splenic artery clamped. Okay. So next is blood film will change over following weeks and Hobble-Jolly body will appear. Post-splenectomy, Hobble-Jolly bodies will be there. Platelets will rise first. And other blood film changes include target cells, Pappenheimer bodies, and the increased risk of post-splenectomy sepsis. Okay, let me tell you. Okay, so let me tell you that the Hobble-Jolly bodies are the nuclear remnants and Pappenheimer bodies are the iron clippings inside the RBCs. Okay, increased risk of post-splenectomy sepsis, and post-splenectomy sepsis is the last. Wait. Okay, so next is the post-splenectomy sepsis. Typically occurs with encapsulated organisms, and the opsonization occurs but then not recognized, usually from the dog bites. I really hope that all of you know what is opsonization. Okay, question number 109. A 25-year-old woman presents with 48-hour history of worsening headaches and fever. On examination, you note nuchal rigidity. Remember the buzzword, photophobia. A neurological examination is normal. So HB is woman. Okay, lower limit normal. Platelets are also normal. WBCs are normal. Sodium is normal, potassium is normal, urea is also normal, crit normal, CRP high, so inflammation is going on. Glucose is normal. Lumbar puncture. So in lumbar puncture you can see that protein is high. Okay, and you can also see the WBC count is also high. So what it can be? They are saying that it is the Coxsackie B virus. So how we will rule out the other causes from the Coxsackie B virus? That the most common cause of viral meningitis in adults are enteroviruses. Okay, the clinical features are suggestive of meningitis. Of course, the nuchal rigidity is suggesting it. The lumbar puncture results suggest a viral etiology due to pleomorphic lymphocytosis, normal glucose, and raised protein. Okay, so you can see that glucose was normal, but protein is high and WBC is also high, and it is a viral meningitis picture. Okay, so Coxsackie and echovirus groups of enterovirus are the most common cause of viral meningitis, and they are the most common cause due to high prevalence of transmission as a tropism for the meninges. Now, why not herpes HSV1 or HSV2? HSV1 is incorrect because the virus is associated with encephalitis in adults. The clinical features in this case are more in keeping with viral meningitis rather than encephalitis, which would typically present with seizures, confusion, and a reduced conscious level. And in 2, it is encephalitis. However, 1 is more complicated. Okay, Neisseria meningitis, CSF, lymphocytosis with preserved glucose suggest a viral, of course, and bacterial will be neutrophilic pleocytosis, and varicella zoster virus is incorrect. Next is viral meningitis. Meningitis is an inflammation of the leptomeninges and the cerebrospinal fluid of the subarachnoid space. Viral meningitis is inflammation attributed to a viral agent. In comparison with bacterial meningitis, it may be considered to be a more benign condition and is much more common. Next is causes. Known polioenteroviruses, for example, Coxsackie virus, echovirus, mumps, herpes simplex virus, cytomegalovirus, and the HIV and measles. Okay, so what will be the risk factors? The patients at extremes of age, but what will be the extremes of age? Children and the elderly, less than 5 and elderly, immunocompromised, of course, and IV drug abusers. IV drug users. Next is clinical presentation: headache, neck stiffness, photophobia. Okay. And a confusion, fevers. Remember that in viral it is comparatively less milder. It means milder photophobia as compared to photophobia in bacterial meningitis. Less common features: focal neurological deficits on examination, seizures suggest a meningoencephalitis. Investigation and management. So opening pressure is 10 to 20. Cell count is 10 to 300. Cell differential. What will be the cell differential in viral? Lymphocytes. Glucose will be to 2.8 to 4.0, of course, and protein. Okay. So moving ahead, PCR may demonstrate an underlying organism. Okay, because we can only say that what type. It may be fungal meningitis due to fungi, meningitis due to TB, meningitis due to bacteria, meningitis due to virus, but the PCR will demonstrate an underlying organism. Okay, so what will be the management? While awaiting the results of the lumbar puncture, treatment should be supportive, and if there is any question of bacterial meningitis or of in CAF, the patient should be commenced on broad spectrum antibiotics and like ceftriaxone and acyclovir. Remember, ceftriaxone and acyclovir. The other stuff is just same. Okay. Which one of the following antiretroviral drugs is most characteristically associated with nephrolithiasis? So these kind of questions when occur is more like remembering the things. Okay. So nephrolithiasis, Indinavir. Remember, there are two N in this, Indinavir, and